Hello, and welcome again to our program, Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center, where I'm a professor of pathology. But our program really is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. Our cases are drawn from the digital slide archives available to members of the Digital Pathology Association. So today we're going to be talking about a case from the realm of GI pathology. So this case is a somewhat unusual, but also not an uncommon problem to encounter at times. The patient was an elderly male with a mostly solid mass in the tail of the pancreas that was discovered more or less actually incidentally in consequence of a CT scan performed for other reasons. So in thinking about this clinical presentation, a mass in the tail of the pancreas, it's not uncommon in today's world of frequent imaging studies to find things incidentally that you weren't looking for and then have to sort out what those could be. So let's just take a look at some of the things that should be considered when you encounter something that specifically is in the tail of the pancreas. First off, there are, of course, the epithelial-derived or ductal epithelial-derived lesions, intraductal papillary mucinous neoplasms, usually giving you cystic type change. Mucinous cystic neoplasms also can occur in the tail, though much less frequently than elsewhere. And then likewise, ductal adenocarcinomas can occur in the tail of the pancreas, though, again, more frequent in the head or the body. What is more frequent relatively is the neuroendocrine-derived tumors, pancreatic neuroendocrine tumors of varying degrees of differentiation. And then we have a group of tumors that are kind of uncertain derivation, the solid pseudopapillary tumor, and then other tumors like acinar carcinoma, pancreaticoblastoma, though, again, a very different age group to be expected there. And then lymphoepithelial cysts, ectopic spleen, and other sort of unconventional neoplasms or unexpected neoplasms in this area, and potentially even things like autoimmune pancreatitis, though again, that's a more frequent lesion in the head of the pancreas. So those are the kind of things that run through my mind as I encounter this clinical story. That may lead then to a biopsy. The biopsy in this case disclosed what looked like a neuroendocrine tumor. So that was prompted by evaluation as to resectability and so forth, functionality, those kinds of things. And this was the result of that resection. We can see here normal pancreatic parenchyma here on the periphery. And then we see this neoplastic proliferation interfacing with this here in various ways. And also here, we see an element of the duct that is involved. So let's go down first over here and take a look and see what this neoplasm is composed of. And in fact, we see here chains and cords of cells, but admixed in here, as you see, are ductal elements. That presents us with an interesting differential consideration. Are these entrapped residual ducts? Or are they part of the neoplasm? Are these a glandular differentiation from the neuroendocrine tumor? And as you can see, the bulk of this solid tumor is nicely granular cytoplasm, somewhat open chromatin with a little bit of salt and pepper and clock face type of appearance. And then fairly similar nuclear appearance in these more ductal-like or ductal type of epithelial cells. That is an interesting possibility to consider, but I think the degree of involvement here is somewhat unusual. There's quite a bit of this tissue. If we look at it at low magnification, I think you can see that probably a third of this tissue here is in this section is involved by that kind of tumor. Looking over here, we see somewhat similar process. As you can see, though, perhaps less of the glandular elements. This area, for example, has basically one or two glands only. And then other areas show even less of this. So the other possibility then is that this is some sort of a mixed neoplasm composed of what appear to be neuroendocrine elements, as you see here, and the glandular elements that we've identified in these other areas. Now, of note here, we can see that this duct is partly involved by certainly by the neuroendocrine tumor, but maybe also as a component of the glandular element. Sometimes it can be difficult to distinguish reactive periductal glands from neoplastic glands in a setting like this. But given the appearance that we've seen elsewhere, it might be reasonable to conclude that some of these might be neoplastic glandular elements. Here again, we see in this area more of the combination of elements. And here we see, again, very well differentiated glandular component, these kind of sclerosis that sometimes we see in neuroendocrine tumors, especially things like insulinomas that may have outright amyloid formation and so forth. But the two components seem to be quite intimately mixed together. And both are still in the relatively well-differentiated category. If we were to go into higher magnification here and look for mitoses, we're really not seeing a lot of mitotic activity. So it's probably actually a relatively well-differentiated neuroendocrine tumor, as well as a well-differentiated adenocarcinoma component. So this falls into the category, I think, of mixed neuroendocrine-non-neuroendocrine tumor, or MiNEN. And the definition of this lesion is that that at least 30% of the tumor is the minority second element. Now, we don't have advanced algorithms that have validated the segmentation and precise morphologic measurement of these components. These numbers are really, to be quite frankly, ballpark numbers based on eyeball estimates of the amount of tumor. And that, of course, is subject to sampling and things of that sort. So when we put this 30% number on the page, I think it's done with a wink and an asterisk to indicate that this is your best guesstimate. But quite frankly, what are you going to do if you say, well, you know, I think it's only 25%, so therefore I'm not going to call it? Well, you might rethink that depending on the kind of behavior you're anticipating and which element, in terms of being more aggressive looking, is in fact the minority element. The usual combination here is a poorly differentiated neuroendocrine carcinoma with pancreatic ductal type adenocarcinoma. But well-differentiated neuroendocrine tumors can participate in this, as evidenced in our current case, as well as acinar tumors as well. So these also can participate as components of this. And in fact, if you take it proportionately, acinar tumors more frequently have a neuroendocrine component than ductal type adenocarcinomas do. But of course, they're far more common as a whole. Using immunohistochemistry is probably preferable to provide more solid evidence that these are indeed discrete elements without sort of an amphicrine appearance, if you will, of both features being present in both types of tumor. And then in terms of behavior, well, the dogma is that the most poorly differentiated component is usually the driving and predictive force of what's going to happen ultimately. But in fact, it's probably pretty similar for pancreatic ductal carcinoma or pancreatic neuroendocrine carcinoma. based on whether or not which one is the higher grade lesion. And in fact, there's at least one study that shows that when you have the acinar component as with your neuroendocrine tumor, that has a worse prognosis than acinar carcinoma or neuroendocrine carcinoma alone. But the numbers of cases and the series are small, so this may bear some watching, some repeating, some monitoring to see if this indeed pans out to be the case. So what did we do in our case? Well, we did apply some immunohistochemical stains. So the usual neuroendocrine markers would be useful in terms of detecting neuroendocrine differentiation, but also neuroendocrine carcinoma often has abnormal p53 expression and will lose retinoblastoma 1 expression. Ductal carcinomas, of course, will express the usual epithelial markers, but also may have some more pancreatic mucinous type markers like MUC1 or MUC3, as well as some keratin markers that would not be expected to be expressed in neuroendocrine tumors. Acinar carcinoma is usually a little bit more problematic to exclude because not every lab will have access to trypsin or to BCL10. And occasionally acinar carcinoma has sort of a weak synaptophysin expression as well. So let me just run through a couple of stains that we did on our case. Here we have, as you can see, the dominant component is the synaptophysin positive component here. And you can see nicely the internal control of the normal islets here in the surrounding pancreatic tissue. As we come into higher magnification and look at, in particular, this area, you will see that the negative staining areas here correspond quite nicely to the glandular element that we saw on the routine H&E. So the neuroendocrine marker, synaptophysin, is marking these diffuse sheets, but not the glandular element. We went the next step as well. It's always nice to have at least a positive stain and one negative stain to confirm your markers. So here is the stain for MUC1 or EMA. And as you can see here, it very nicely highlights the glandular elements all through here and is entirely negative with the neuroendocrine component. So this then was classified as a mixed neuroendocrine and non-neuroendocrine neoplasm that is actually composed of well-differentiated components for both elements. In this situation, most likely it would be this well-differentiated adenocarcinoma component that would drive the overall behavior. But given that that is the minority component in this lesion, and maybe only 30% or more at this stage, even with a liberal estimate, we might have lucked out in this case, and the patient may do well. So just a couple of things about neuroendocrine events. If you consult path outlines, as I did here, you'll see that TP53 and RB1 will be mutated in the neuroendocrine component, as we've just mentioned. Ductal carcinomas, of course, have the complement of stains with KRAS, CDKN2A, SMAD4, of course. And acinar carcinomas may be more likely to show APC mutations or beta-catenin alterations and even BRAF mutations if you're interested in investigating those and highlighting which ones are or are not present, particularly if you're thinking one is going to be the driver neoplasm and you want to potentially treat that more aggressively first. Looking for potential targeted therapies for these agents might be of some use. So that concludes our case. Our final sign-out diagnosis was mixed neuroendocrine and non-neuroendocrine tumors, well-differentiated pancreatic neuroendocrine tumor and well-differentiated pancreatic ductal carcinoma. So with that, I thank you for joining me. I hope this has been useful to you. And if you like that, please hit that like button and subscribe to our channel so that you'll catch future releases as we intend to continue to provide new content on a fairly regular basis. We welcome your comments and hope that you'll feel free to communicate with us if you have questions. comments or additional ideas that you'd like to share or suggest for future programs on the channel. So until next time, thanks so much for joining me.